Okay, so I think we're going to get started now. Welcome to the first ever Washington University Shoulder and Elbow live Facebook chat. Today we're going to discuss rotator cuff disease. My name is Jay Keener. I'm an orthopedic surgeon, shoulder and elbow specialist at Washington University. I've been here since 2006. I'm a professor and of orthopedic surgery and chief of the shoulder and elbow service for a few years now. And we're excited to kind of talk with you guys today, maybe answer some questions about rotator cuff disease. With me is...
I'm Dr. Alexander Aleem. I'm also a shoulder and elbow specialist at Washington University. I've been back as a faculty member now for almost 5 years, about 4.5 years. Time flies, but I'm excited to talk to a guy that I learned a lot about rotator cuff disease, and I still learn a lot from. So Jay, maybe kind of what is the rotator cuff, and sort of why is it such a big problem for people?
Sure. So first of all, rotator cuff disease is far and away the most common cause of shoulder pain. And we see people in their young patients, middle-aged patients, and elderly patients. The rotator cuff is a group of 4 muscles that surround the ball and socket joint. There's one tendon on top called the supraspinatus, one in the front called the subscapularis, and 2 in the back. And the problem with the rotator cuff is as we get older, the tendons become a little bit stiffer. The supraspinatus tendon loses its blood supply, and then the normal wear and tear we put on the shoulder just from our normal activities of daily living can cause some inflammation, and actually can get some fraying of the rotator cuff, which can create pain, limitation of motion, inflammation. The spectrum of disease that we see with the rotator cuff ranges from tendonitis on one end all the way to this disease process called cuff tear arthropathy on the other end. And most people that we see with pain are kind of in the middle. They're middle-aged patients who have fraying, which is called partial thickness tearing of the rotator cuff, or you can actually develop a small hole in the tendon known as a full thickness rotator cuff tear. And one of the common misconceptions about why people get cuff tears has to do with, if you think of a tendon tear, you think of an injury. And a lot of times with the rotator cuff, there's no injury. It's just a combination of general activity and getting older, basically. I think of the rotator cuff as kind of, when you reach your middle ages, you get gray hair or you go bald. The rotator cuff develops tendonitis, tendinopathy, starts to fray, becomes inflamed, and it can be very painful. And usually patients are presenting to the doctor primarily with pain at nighttime. So maybe, Alex, you can talk about some of the common symptoms that patients might have, and maybe when they should think about seeing a doctor.
Yeah, I think it can range, but I think pain is probably the biggest thing that drives people in to come to see us. And shoulder pain can be kind of difficult sometimes, because the way you and I think about the shoulder is very different than sometimes when we're talking to patients, they think about the shoulder. But rotator cuff pain sort of kind of very typically sort of affects what we call sort of the lateral, the outside border of the shoulder. So if you feel kind of pain that's sort of running up and down the arm, sometimes it'll run down to the elbow. That makes us kind of worried about rotator cuff pain. Pain with certain activities, especially kind of reaching overhead. So if you've noticed that you're trying to put some, something away in a shelf, or overhead activities, so tennis players, swimmers, and starting having pain, that's another thing. You mentioned nighttime pain. That's probably one of the biggest things that I think brings people in to see us. Is you can kind of deal with the day-to-day pain, but as soon as your sleep gets affected, it can really cause a lot of problems. If you don't get a good night's sleep, it just affects you a lot. So nighttime pain is another really big thing to look for. And I think another thing, you mentioned that most of these injuries and most of these pain things are not associated with trauma, which is probably true of the vast majority of the rotator cuff tears that we see. But if you do have an injury, you do have something where you fall, you feel something jolt, and you notice that pain, that's a completely different sort of situation a lot of times. And so that would be a reason to come in and see one of us for an evaluation, rather than sort of these atraumatic kind of degenerative pains. If you notice weakness, I think that's another reason to probably come in sooner rather than later. So if you start noticing pain and weakness reaching overhead, or limited range of motion, I think are the other things that I would say.
Yeah. And when you come in and see a doctor, an orthopedic surgeon for shoulder pain, we typically will go through a history and take x-rays of the shoulder. The x-rays are primarily to rule out other problems like arthritis or fracture, for example. Some patients, this is a minority of patients, but some patients can develop a little bone spur in the roof of over their rotator cuff that can predispose them to having what we call impingement. When they bring their arm out to the side, they can develop sharp catching pain in the shoulder, sometimes radiating down the arm. The impingement pain is kind of one of the classic findings. The other exam finding is loss of motion behind the back, but we're very careful to make sure that the history and the physical exam kind of lead us down the correct diagnosis, because many times the x-rays are normal, or they show just some mild age-related arthritis. But if there's a concern for a rotator cuff tear, sometimes we can order advanced imaging if needed. Sometimes we will just manage it non-operatively. Alex, what do you typically recommend if somebody has an exam that suggests cuff pain, but you're not too concerned about a tear? What would you typically recommend to help manage the symptoms?
I think for me, first line treatment is physical therapy. I think it's been shown to help, especially without any sort of objective weakness. If it's mostly just pain, we've got great resources that show that physical therapy can really help. A lot of it is not just the damage in the rotator cuff, but also sort of the mechanics of the shoulder blade muscles as well. And I think therapy can really help with that. And we've really seen, even in patients that may have a tear, therapy can really help. Cortisone injections are the other thing that you hear a lot about. My personal philosophy is I don't love to just give injections straight off the bat. I think, I like to, unless the pain is really bad, nighttime pain is one of those things for me that I tend to be a bit more aggressive with the cortisone injection. Speaking of nighttime pain, we got a question asking kind of what causes nighttime pain. Why do we notice it more at night? Jay, this is a great question because I think we ask ourselves this all the time. I have my own sort of theories. What do you think causes nighttime pain?
I think the anytime you have pain at nighttime in a joint, it's usually a sign of an inflammatory process. So it's the inflammation around the tear. And for some reason, whether it's immobility or lack of movement or just laying flat, that changes the blood flow. Active inflammation always hurts worse at nighttime. So I think of nighttime pain and with rotator cuff patients as a sign of active bursitis or inflammation. So, many people really can't tolerate even just laying flat, much less laying on that side. So sometimes it helps to sleep a little bit more upright. You mentioned earlier, nighttime pain is a good indicator for considering an injection in the shoulder. It's one of the more debilitating symptoms. When do you consider doing advanced imaging, Alex? So like what imaging tests would you like to order, and when do you do that?
I think
Does everybody need an MRI?
That's a great question. I think one of the things that we see a lot of are people come in with MRIs that have been told that you have a rotator cuff tear. But it's either a partial tear or it's a small tear or it's a large tear. And sometimes the MRIs don't really help a lot in sort of the initial management. I think it depends a little bit, but I think if we look at sort of our typical patient, which would be somebody in their 50s and 60s that, no trauma, has had pain for several months. For me, that's somebody that I would start with physical therapy plus or minus an injection if they didn't have a lot of weakness. If they have a lot of weakness and I'm worried about really significant tear, then I think I tend to get the advanced imaging a little bit earlier. But if they don't have weakness and they don't have loss of motion, if it's just pain, I think we can usually get people better without having to get the advanced imaging unless they kind of fail that. I think a lot of people think MRIs are sort of the only test that you can get for rotator cuff tears. MRIs are great, and we see a lot of MRIs and I get a lot of MRIs. One of the things that makes WashU really special is ultrasounds. We've done a lot with ultrasound with the shoulder. We've got a really good program with it. We've used it to do a lot of research that's actually helped us, understand rotator cuff tears a lot and kind of understand how they progress and sort of who is at risk for having more problems. Jay, what about you? Is it ultrasounds, MRIs for everybody, or is it kind of case by case?
It's a case by case. You brought up a good point. When there's a lot of weakness, as if there's a history of trauma and there's weakness on the exam, that's a pretty solid reason to check a imaging study, because the way we manage traumatic tears is slightly different than degenerative tears. But a lot of times patients want to know what's wrong with their shoulder, and if they've had pain for more than 3 months and they have a cuff exam and they're in a high risk age group, which is probably over 60 to 65, you can make an argument to image them. We do like to use ultrasound a lot. It's very inexpensive. You don't have to lay in a scanner. It's just as accurate as an MRI. So that gives us a little more freedom and flexibility on ordering advanced imaging. And a lot of times the insurance companies don't put as many barriers in front of us to order an ultrasound as compared to an MRI. But I think there's a lot of individual variation from surgeon to surgeon on who to get an MRI on. But one of the things that you brought up is very valid, is the physical exam and the history have to match the MRI findings. So many times you'll see a patient, I'm sure Alex, you see this a lot. Patient comes to you, they've been told they have a partial rotator cuff tear, and you examine them and it's clearly a frozen shoulder, for example, or they have biceps pain. So, and the treatment for those is completely different than how you would manage a rotator cuff tear. So it's really important that your doctor or your surgeon take the time to listen to your history, listen to where your pain hurts, what aggravates the pain, lay hands on the shoulder, go through a good range of motion exam, a good strength assessment to make sure that what you're actually complaining of in your exam findings actually fit what you see on the MRI.
Yeah, I think that's a great point. And one of the things that we've learned here at WashU from the ultrasound studies is that people have rotator cuff tears in their shoulders and may not even know it. 50% of people over kind of 60, 65 will have some sort of rotator cuff disease. And so it's a really common finding that we'll find on an MRI, and it can lead people sometimes down the wrong treatment pathway for a long time. And so I think frozen shoulder is a great example of someone that has, gets an MRI that may have a partial thickness tear, but they're going to PT to try to strengthen their rotator cuff when they need something completely different.
Right.
So yeah, I think the imaging studies are great, but they have to be, I think, fit in perfectly with history and physical exam, as you said, and that's really the most important thing.
How do you manage a rotator cuff tear, Alex? Let's say a full thickness tear in a 60-year-old that's tried therapy, maybe got a little better. They've had an injection, it still bothers them, and they're still having issues. Can you talk about a little bit about what the role of surgery is, when you should consider that, and what's actually done?
Yeah, no, I think that's kind of a perfect example of a patient that would benefit from surgery. Kind of 60-year-old who's had pain for a long time, has a full thickness tear, and has not been able to benefit from management. Rotator cuff surgery comes in various different varieties, but for the most part, the goal is to repair the torn tendon. We at WashU, I think all of us do these techniques arthroscopically. So that basically means small poke hole incisions. We put a camera that's about the width of a pen into the shoulder, and we have various instruments that we use to be able to really inspect the shoulder joint as well as the area around the rotator cuff, get into that area where that bursitis is, kind of over the rotator cuff, clean all that out and really inspect the rotator cuff tear, be able to measure it and kind of see it. We always get idea from imaging, but then the repair would be kind of what we would do as well arthroscopically. And there's tons of different techniques to do it. I think that's something that surgeons sometimes go blue in the face talking about their technique, but I think at the end of the day, all the techniques are really good and they do well. But the goal is to basically restore that tendon back to the bone where it was torn and make sure that the repair is strong enough to withstand normal forces as it heals. And that's kind of a typical rotator cuff surgery. There's some other things that happen during a rotator cuff surgery. Sometimes you hear about a decompression or an acromioplasty, which basically means we kind of take off that little bone spur that you had talked about. A lot of times, as you mentioned, biceps can be involved with rotator cuff pain, and that's something that we sometimes associate, and we sometimes prevent do surgery to help with biceps pain as well. I always tell patients the surgery part's relatively easy. You know, that's an outpatient surgery. We can do it at one of our outpatient surgery centers. It's really easy. They get a nerve block, but the rehab is really tough. Jay, you know, you have a physical therapy back. What do you tell patients about rehab after rotator cuff surgery? Because I think that's probably the hardest part of it.
Yeah, I think you bring up a few good points. Number one is you got to remember on a properly indicated surgery patient, the surgery works very well. So in terms of like having a happy patient, having good range of motion and strength, that happens over 90% of the time. But the difficulty is getting from the surgery date to that time frame, and the healing process with rotator cuff interestingly, can take longer than a shoulder replacement, for example. The biggest issue is the early 6 weeks. So the thing that bothers people the most is the pain at nighttime, and that's related to the inflammation created at the time of surgery that's needed for the repair to heal. So people wear a sling. We let them come out of the sling and move their elbow and their hand, but they really can't lift their arm away from their body for about 6 weeks. There's some therapy involved to kind of keep the shoulder from freezing, but you don't really graduate from your sling and start moving the arm on against gravity until 6 weeks. And then we don't start strengthening until 12 weeks. So that's 3 months before you're doing any rotator cuff strengthening. And from there, it takes anywhere from 2 to 3 months to build your strength back. So you always have to educate the patients that it takes about 5 to 6 months to get fully recovered. We let you do different things along the way as you reach the different milestones in rehab. But if your goal is to know, when can I play tennis or swing a golf club or start to swim again, or go back to a medium labor job, that can take 4.5 to 6 months. Depending on the size of the tear and the age of the patient. Alex, we've got a question here. Why does a heating pad sometimes work for the pain? When your shoulder gets cold at night, it can ache a little bit more. Why is a heating pad better than ice, or is it?
Yeah, I think I think a lot of it is anecdotal. I think heat and ice are both great modalities for inflammation. Heating pads, some of my patients swear by them, and some of them hate them. Some of them swear by ice, some of them hate them. I sort of, at least for me personally, heating pads I think are really great as they kind of relax musculature. I think they really help decrease inflammation, especially at nighttime. If you're having some pain, it can kind of help with that sleeping. I think there's just something about kind of that warm feeling on the shoulder that can really help. I also think it's great as an adjuvant when you're kind of getting ready to do therapy. Can kind of warm up the shoulder, get the shoulder muscles relaxed. And then ice can be a really good modality after you're finished, can help with swelling, help with kind of decreasing inflammation. What's your take on the heat versus ice?
Yeah, and I agree with you. A lot of it is based on patient comfort, and it's different for different people. I think one of the general mantras about heat and ice is if you're after a recent injury or if you had a recent surgery, probably for 3 to 4 weeks, ice is better because it has more of an anti-inflammatory effect. But as you get further out from an injury or surgery, heat tends to be more soothing. So I don't think it's wrong to use either one. You probably wouldn't want to put heat on an early injury because that can make the inflammation a little bit worse. But there's a lot of individual variation, from patient to patient, which one feels better. If somebody's using heat at night and it really helps, their pain might actually be muscular, or it might be related to arthritis rather than rotator cuff issues. So it's important to know kind of what you're treating. So Alex, maybe you can tell me, here's a question. What is an intrasubstance rotator cuff tear?
Yeah, so that's something we don't see a lot. So when we talk about rotator cuff tears, we mostly talk about kind of, if I were to use my crude hands here. So if this is kind of the ball part of your shoulder, the rotator cuff muscles kind of run over and attach to sort of the outside part here. Most tears kind of occur at that attachment. So they're called tendon tears. Tendons kind of attach muscle to bone. An intrasubstance tear would actually be a tear that kind of occurs in the muscle or kind of in the tendon itself. And we don't see those as often. Most of the time we see tears kind of coming off. The question is, are there precautions? This is a question that we get asked a lot, I think. Someone comes in with a full thickness tear or a partial thickness tear. Are there precautions that we have, for rotator cuff tears? Is there something that's going to potentially make it worse? I think, we talked about the activities that maybe exacerbate pain, but what do you tell patients? Are there any activities that you tell them to avoid with tears?
Yeah, people with rotator cuff tears in general, they do worse when they're lifting away from their body. So with the longer the arm, the more force across the rotator cuff. So if somebody has to lift something a little heavier, I tell them to keep it closer to the body. I think generally people do well lifting below shoulder height if it's not too heavy. The other restriction to avoid is a lot of overhead lifting. Overhead motions can be a problem if the scapular posture isn't good, but you really get into trouble when you're lifting overheads in any particular weight. So I think general guidelines are avoid arm positions that cause sharp pain. We're lifting heavy, keep it closer to your body, and avoid a lot of overhead lifting in general. That's whether you have a cuff tear that's being managed non-operatively or if you're recovering from surgery as well. Once you get fully recovered from surgery, generally people don't have a lot of restrictions. And in general, really heavy weightlifting, powerlifting is to be avoided, but people can return to racket sports, mowing their yard, shooting a gun, hunting, playing golf, playing with the grandkids. Physical demands, light weightlifting is usually pretty well tolerated. Yep. So Alex, there's been a lot of discussion lately on using a PRP or stem cells for rotator cuff problems. What is that, and does it work?
So two great questions. So we see a lot about PRP and stem cells, a lot of advertisements about it. PRP, they're kind of both the same, but PRP is this thing called platelet-rich plasma. And essentially what it is someone takes a sample of your blood and it gets drawn off and put into this machine that kind of spins it down and comes out with supposedly a kind of solution that's got a really high concentration of sort of growth factors that naturally kind of stay in your blood. So the idea is that if you inject into a site of injury, it should stimulate healing and stimulate kind of a better response. This has been studied because rotator cuff surgery, while it's really good, a lot of times one of the dirty little secrets of it is not every repair heals. And so how can we make sure that every repair heals? Right now, there's not a lot of evidence or not a lot of data that would convince me that it's really something that I would put into a repair. There's a lot of differences in terms of the concentrations, in terms of how it's made, and also in the delivery system. It's also fairly expensive. So it can cost, hundreds to thousands of dollars. And so for me, it's not something that I really think about putting in to augment the repair, but I think it's something that we're trying to study to understand if we can use it to help with healing and help maximize outcomes. What are your thoughts on it?
I think that PRP and stem cells, a lot of the questions that I get from patients are, should I do this instead of surgery? And which is better, a steroid injection or PRP? What I tell patients is there is some evidence that PRP or stem cells can help improve symptoms. It might modulate inflammation to some degree. It might help you rehab a little bit easier, but it does not promote tendon healing. There's absolutely no science that actually shows that there's tendon regeneration or a healthier tendon afterwards. If you have a healthier tendon after a PRP injection, it's usually because you've had some pain relief and you can do more effective physical therapy. So it is a more natural way to treat the pain. I never discourage a patient from trying it. Some of the tears that we see are very severe, and you kind of know in the back of your head that the PRP or the stem cells aren't going to help much. But I think it's a reasonable thing for a younger patient with a less severe tear, especially if they're trying to avoid surgery.
Yeah.
You just got to make sure that you understand what it's doing. It's not actually making the tendon heal, but it can modulate some pain response.
Yep.
So Alex, maybe you can talk a little bit. We have a question about the role of the scapula or shoulder blade in shoulder pain. And I think that's a really good a really good question because it's oftentimes neglected by orthopedic surgeons. Physical therapists know a lot more about
Yeah.
proper shoulder mechanics and how to address faulty movement patterns. And what are your thoughts on the role of the scapula with shoulder pain?
I think it's huge. I think it's one of the things that, I remember learning from you as a resident, and something that I really pay attention to, because it can be sometimes ignored by the physicians, and really is like an important factor with improving rotator cuff pain, or even just general shoulder pain. We've seen it all. Our society is, we're sitting in front of computers, our shoulder blades start kind of tilting forward, and so to get that proper posture really is important, and I think is a key to any therapy program, either for non-operative management or for surgical management for rotator cuff disease. You got to have a good shoulder blade. You have to have a properly working shoulder blade to have a good working shoulder joint. It really does, I think, play a big factor to it. So it's something I really emphasize with my programs.
Okay, I agree. I think it's neglected, and it's amazing how well you can take somebody with recalcitrant impingement, and if you just address the shoulder blade mechanics with a good, knowledgeable therapist, it can make a huge difference.
Totally
So
agree.
I'll take this question here. Should you expect to have arthritic change after a traumatic rotator cuff repair? So so if you've had a repair and the tendon is healed, the chance of arthritis is relatively low,
Absolutely.
unless you had a shoulder dislocation that caused the initial tear, in which case you are likely to have some arthritis a few years later, but nothing that's rapidly progressive. If you have a large rotator cuff tear that's either not been operated on or has been operated on and didn't heal, what happens is the ball tends to migrate up in the socket because of the deltoid muscle, and it throws off the mechanics of the shoulder, and there's some edge loading on the cartilage, and over time you can develop a pattern of arthritis called cuff tear arthropathy. But in general, if you've had a successful repair of a traumatic tear, I don't think you have to worry about arthritis that much.
I, I totally agree. I think there's some conditions that we see dislocation probably being the one that would put you at risk for developing arthritis after a rotator cuff repair. But if you've had a successful repair and the tendon heals, very low chance. We've got a couple minutes left. Maybe talk a little bit briefly. I know we've talked a lot about repair. What about reverse? You talked about cuff tear arthropathy, arthritis in the setting of a cuff tear. What's this whole reverse thing that we keep on hearing about?
Yeah, so a reverse shoulder replacement is a type of a complete replacement where the joint is flipped. It's a metal and plastic replacement. It's basically designed to change the mechanics of the shoulder. So if you have a rotator cuff tear that's irreparable, meaning it's successful repair is not achievable, or there's already pre-existing arthritis with that rotator cuff tear, the reverse can really, really improve the shoulder mechanics, improve your elevation motion, improve your strength away from the body. And because the success is not reliant on cuff healing, what it does is it changes the mechanics of the shoulder, makes your shoulder less dependent on the rotator cuff, more dependent on the deltoid. The recovery is faster and it's more predictable. So you don't have to worry about that 20-30% chance of re-tear that you can see with the cuff repair. With the reverse, usually 90 to 95% of patients are pretty happy with the functional improvement. So all right, so I think I think our time's pretty much done. Alex, Dr. Aleem and I would like to thank everybody for your time. We could talk for 3 hours on rotator cuff problems. There's so many different facets to think about. And I think one word of advice is if you're having a lot of pain at nighttime, particularly with weakness, probably see somebody for that, whether it's your physical therapist or your primary care doctor. Come visit us at Washington University Shoulder and Elbow. We're very happy to take care for you. We take care of you. We provide cutting edge medical care, and just because you're seeing a surgeon doesn't mean that we're going to recommend surgery. So we want to educate you, teach you about all the options, and let you make the best decision for your shoulder. So thank you for your time. Alex, any parting comments?
No, I agree. Thank you for taking the time to watch. Like you said, I think we could spend days talking about the rotator cuff if it was just the two of us.
Right.
So it's
Shoulder
an interesting thing. Yeah, totally shoulder nerddom. But I think the reason that we can talk about it so much is treatment really is individualized to a certain patient's needs. And I think that's sometimes a difficult thing with rotator cuff disease as well, is it's not a one size fits all treatment. It really is trying to take the entire story, physical exam, imaging, everything into consideration. And I think that's why we do a good job of treating it at Washington University. I think we're really, as you said, we're up to date on the treatments. Even though we're surgeons, we are very likely to not recommend surgery the first time you see us. We're going to try to get you through to make sure that we have your pain well managed and getting back to an activity level that's reasonable. So we're always happy to kind of see you and make sure an individual program works well. Thanks again, everybody, for watching. Really appreciate it. And feel free to
Thank you,
come by and
everybody.
see us anytime.
Okay.